On June 5th, 2017, The Economist magazine proclaimed that oil was no longer the world's most valuable resource, it was data. It's a nice quote, but practically what the heck does it mean for healthcare? On this Vital Health podcast, I'm very pleased to be joined by Judsen Schneider from Nashville Biosciences, the Chief Technology Officer. Hello, Judd. How are you doing?
Yes, doing great.
And I'm also joined by Curt Allen, the VP of Sales. Hello, Curt.
Pleasure to be here. Thanks for having us.
So can you two gents tell me a little bit of the history of Nashville Biosciences?
Nashville Biosciences actually begins well before the company actually formed. It began around 2010 when some researchers at Vanderbilt got together and decided that to create a preeminent database of all clinical data as well as biospecimens. That became BioView, and that has been used for a wide variety of different purposes within Vanderbilt. Importantly, some key things were included in that. One was patient consent. So all patients were consented to participate and donate their data for research. And then also, too, there were some rules of the road around what the data could be used for. And what Vanderbilt realized over the years was that research doesn't just happen inside the walls of academia. It actually happens more broadly within the, biotech and pharma ecosystem. And so they created Nashville Biosciences in 2018 really to help get that data out into that ecosystem, to allow for that data to be used to create new drugs, new treatments for disease, and really to help broaden the impact of that resource. And so we were founded in 2018, and we've been steadily growing since then.
So from the standpoint of assets, if you think about the major research institutes in the United States, obviously there's an enormous coastal bias in this country, as if sitting next to an ocean confers some level of intelligence that doesn't exist in other places. I mean, what is it about Nashville Biosciences that makes it special? The relationship with Vanderbilt, I know, but do you find that there is this bias, and how do you handle this from Nashville, Tennessee?
Yeah, so Nashville, Tennessee, it actually is a really big healthcare hub in the U.S. So 80% of all the healthcare beds across the United States are actually operated out of Nashville, Tennessee. And that's because a lot of the major hospital corporations have had their start there. And there's a really great ecosystem for helping encourage healthcare companies to get started and prosper. And so that unique asset coupled with this data asset really allows not only the talent, but also the understanding of how healthcare data can be applied to really, enable us to go out there and do what we do. Yes, there is coastal bias. I think there's a lot of interesting research that happens on the coast. There are wonderful places to live, and there are a lot of great ecosystems have started there. But Nashville itself is pretty unique. It's got a lot of data companies, and it's got a really burgeoning biotech scene as well. I was actually on the board of Life Science Tennessee for about 10 years, which is the Biotech Association, and it's steadily grown since then.
So, Curt, you're from the South. You grew up in New Orleans.
Correct.
But now you're working at Nashville. How do you see the ecosystem evolving since you've been working for Nashville Bioscience? There's a huge amount of growth in the biotech sector in Nashville. It's crazy. Yeah,
it's huge. If you look at our data set that we spoke with, so the data set for the EHR is about 3.8 million patients right now, and we're taking on about 200,000 per year. So you look at Nashville and the West Coast bias that we spoke of, if you also look at the diversity of that data and what those patient populations look like relative to where they're coming into the system, that's going to be another component where you're going to see a lot of growth in the data itself as well.
So what do you attribute to this growth in Nashville for a healthcare hub? It's obviously been one of the largest growing. It's been in the top 5, depending on how you slice it. Is it people assets leaving California, Illinois, New York? We're seeing a lot of exodus there. Is it that? Is it just organic growth from the community? Well, how do you see this working?
I think it's become, if you look at Nashville, you look at all the healthcare from a higher level, from a company standpoint. Tennessee's done a good job of recruiting companies, frankly. And so you compile that with a good academia environment with researchers that want to stay, with a culture of healthcare at a higher level that wants to be there. And then you do that and you grow that over a period of time, you're going to see that growth continue to help the community out.
Now, Judd, you're somewhat unique in that of the team. You're based here in La Jolla in California.
Yeah.
What was the motivation for Nashville to sort of broaden out and sort of get here? Is it just to tap the bigger California market per se?
Yeah, a lot of it has to do with, we, like most companies, went fully remote when the pandemic hit. But we've actually really, taken that and used that as an asset to grow our talent base quite a bit. So, yes, having presence in the markets where our customers are is really important to us, because we really try to connect with our customers to help them understand the data. So if we can physically be there and help them with that, that's definitely a big asset that we have. So we've been able to source from all across the country and even in Europe as well, some really strong talent to help us grow.
Now, on that note, speaking of Europe, we first worked with NashBIO in 2018 on a contract from the Dutch government.
Yeah.
Ironically, the Dutch had asked us to prospectively look at a new class of treatments called CAR-T, CAR-T therapeutics, which it turns out Vanderbilt University had one of the pivotal clinical trials for Gilead Sciences for this new class of therapeutics. We developed a relationship with Brian Rothman, who is now the chief of revenue and the chief policy officer and the chief business officer of the entire hospital. And so he put us in contact with NashBIO. And of that, we put in a pretty groundbreaking study to show that you could use real-world evidence to develop an economic model against the standard of care. We even got a pretty seriously cutting-edge publication in the British Medical Journal, still ranked as in the top 90% of impact. So a really successful project, and it was a great opportunity to work with you guys. It was a fantastic relationship. But that's 5-6 years ago. How have you guys evolved since 2018?
Yeah, so we've evolved in a number of ways, but what hasn't evolved really is our commitment to our customers and helping them understand the data. It is, like Curt said, it's, millions and millions of clinical health histories that have been donated. And one of the things that we do really, really well is help our customers understand how to use the data well, how to derive the insights they need, and then we kind of coach them in other ways to use the data. So while we've grown as a company, that commitment has stayed.
So, Curt, from your standpoint, are people mostly coming to you and saying, hey, we need this, and how do we work with you? How does a normal relationship work for a new client?
Yeah, you'll hear the term, we want to meet customers where they are. I think the other piece is you look at the data from 2018 to where it is now.
Yeah.
You've heard the saying, ye who has the most data wins. Now that data is becoming so vast, so broad, a lot of times it's hard to digest just from storage and compute cost. You start to see now, ye who owns the insights wins. Right. So a lot of people, instead of owning that data, they're really wanting to tap into what those insights look like.
Yeah.
Now, does that get into what the Alliance for Genomic Discovery? This is a new platform you've rolled out. Is this sort of that developed that next phase to give the insights? Is that what you're trying to do?
I think it is. So the Alliance for Genomic Discovery was started with, Judd touched on it earlier. So if you look at BioView and the number of samples we've taken through 2007 up till now, we're taking on, we have the capability to take on about 40,000 a year. So we are up to about 350,000. Out of that, we said we want a whole genome sequence, 250,000 of it. To do that, it costs a lot of money. So in order to make that happen, there was a consortium brought together with 8 pharma partners to make that happen.
And who are the partners, just out of curiosity?
AbbVie, Amgen, BMS, Novo Nordisk, GSK, AZ, and Bayer.
So a lot of the big players, a lot of them working in cardiovascular disease.
Correct. Correct. Yep.
So do you see a change in the clinical indications that you've been working at? Because when we did this, it was mostly oncology, but there seems to be, particularly with the Inflation Reduction Act, and we're predicting this in some of the research we're seeing a shift away from oncology into old school cardiovascular disease, party like it's 1999 again. Are you picking this up in the client requests too?
It is. I think if you look across most people, most large companies, if you look at all their investor relationships, where they're putting their R&D monies, where they're doing their targeted drug discoveries, you're going to see it's still going to remain cardiac, neuro, and onco.
Yeah.
Cardiac is big. From our standpoint, going through the Alliance for Genomic Discovery and doing the whole genome sequencing, you pick up a lot of genetic components that lead to cardiac as well. And a lot of people are focusing on that. HCMs being probably one of the biggest one.
Yeah.
You need the ECGs, you need the echo measurements, you need that data that's usable in a flat table, easy to digest for these companies to go and start using it.
So Judd, here in California, are you seeing a similar move as well?
Yeah, absolutely. I mean, these corporations have global footprints, so it's definitely shifting. But we've seen it evolve over time. I mean, NASH was really big a few years ago. Now, definitely cardiology is coming more into flavor.
That's interesting. So if we look at this from the standpoint of all the hype around AI, okay? Now, I'm old enough to remember IBM was a client of mine back in another job I was working with, another organization, and we did a lot of work around Watson. Watson failed miserably when they tried to make it into healthcare diagnostics. It just didn't work. I mean, in fact, now they're giving away the platform for free to collaborate with universities. How do you differentiate between AI and the hype around it and its actual practical application? How are you folks handling this AI situation, and what are you doing with it, if anything?
Yeah, so AI is just like any other tool. It's going to have a hype cycle that goes through, but really it's those focused practical applications that make the big difference. We have our own AI strategy, but also too, we are actively working with customers to help them further their AI strategy.
Sure.
So we have vast amounts of data, and you need vast amounts of data for good AI. And so, we've partnered with a couple of organizations to really help them move that forward.
Now, Curt, you mentioned this earlier, that rather than being a mile wide, you'd rather be, a little narrower and a mile deep. Now, there is a lot of movement of assets to China. We've seen a 10 times increase in certain neurology research, amyotrophic lateral sclerosis. We've seen enormous increases in Chinese clinical research there. There's 1.3 billion people in China. You have 3 million people in your data set covered lives longitudinally. How do you square the circle? What do you define as the competitive advantage, given the fact that in China, even if you're a 1 in a million person, there's 1,000 people just like you? What is the secret sauce that makes you guys a winning combination, I guess?
I think for us, you have that data, but statistically, you're going to get to a point where you're going to have that point of no return. So I think we're going to have that data to meet it. If you look at what our customers are really looking for, it's that retrospective, longitudinal, multimodal data that they can harmonize across a certain period of time for these patients. So I think population is in the numbers being big is important to a certain extent, but it really goes back to what I was saying. It's not about ye who has the data wins, it's ye who has the insights that's really going to draw that out.
The other thing I'll add too is that the diversity of our data set from the simple genetic background of people is incredibly vast. A lot of biobanks have grown up and been used in a lot of European countries that have somewhat homogenous ancestral backgrounds.
Sure.
Whereas the Southeast U.S. is a very, very diverse population. So we get an opportunity really to peek under the hood at a lot of really interesting genetic diversity that draws on people from all over the world and their ancestral backgrounds.
And I think that's also endemic to the situation you have at Vanderbilt University. And I don't think a lot of people realize when you say Vanderbilt, there's an entire health network, community health, everything that gets captured in the catchment area of that hospital. When we started looking at the numbers of people who were being treated by CAR T, it's like, wow, this is on a par with, UPenn, which was one of the development hospitals. It's like, wait a minute, we got similar numbers, because Vanderbilt's footprint goes all the way down into Louisiana, into parts of Texas and the Panhandle, all sorts of reach there. Do you guys get to exploit that? Well, in the best of terms, I guess.
I wouldn't use that term, but
Yeah.
I think, Vanderbilt is a unique place because it is a center of excellence for a large number of, clinical centers. And also, too, I can't understate the generosity of the South, people in the South, for donating their samples and donating their clinical health histories to this. So it's really, yes, it's Vanderbilt, but it's also a big testament to the people in the Southeast U.S. who are very willing to donate their clinical health histories, donate their DNA, and consent for this research to really move forward.
And the other thing that we found that was really interesting is we were able to work very closely with some of the clinical teams. While we don't get access to the PPI, the protected information, the clinical teams were able to go in and say, oh, we did see this in the notes. We did find this. And again, we were dealing with a very small early population. I think it was 23 CAR T patients. But it seems like you have a very good relationship with very senior people in the clinical side at Vanderbilt University.
Yeah, I think having that, I would say it's 1 degree of separation. So for our team to be able to pick up the phone and touch base across those centers of excellence, those key opinion leaders that reside clinically within Vanderbilt University, allows us to push that data out, to Judd's point, take that generosity that's been brought in and then turn around and be generous in pushing that back out in a very specific and conscientious way.
Now, you mentioned you're doing more work in Europe. We obviously were working, I'm based in Brussels, although we're spending more time in my DC office. But what we've found, and the reason why we initially approached you in 2018, was the general data protection regulation in Europe really precludes a certain amount of availability of large pseudo-anonymized data sets. You can't do it under the current regulation. Are you finding that based on your systems, you're managing to develop an opt-in approach that allows you to work in Europe, or is it really just taking your data and bringing it to Europe to be able to do the kind of research we did with you folks?
Yeah, right now it's taking our data and allowing Europeans to use the data.
Yeah.
I think a lot of the data protections that are out there are very good and have well intentions. One of the things that we've had to navigate, ourselves is within the usage rights that the community has set up for BioView, and that's just a wrinkle that we have to work around. But we've been able to create this and help further this de-identified resource and really power, and shape the data in ways that can be used and work around some of those challenges, but also maintaining patient privacy and protections that they require and need.
So you've had enormous growth, obviously. The team's expanded hugely since we worked with you folks. 4 or 5 times. Fantastic. Congratulations. Salute. Chapeau. Where do you see this moving 5 years from now? What do you think the next trends are? What do you need to be on top of? What's the evolution going to be?
I think you're going to continue to see specificity of the data. I think the genetic component is probably first and foremost front and center in what everybody's doing, because you can draw off of that. I think if you look at that and apply that to companies, their portfolio prioritization, how they're going about doing their targeted drug discovery, the speed at which they can now get through all their different clinical phases to get to that FDA approval or make a decision to not move forward, as part of that portfolio prioritization and that specificity that you're gaining with the data you have access to. I think that's what it's going to be like. It's, data doubles and doubles every couple of years. You're going to start to continue to see that, and how that transforms into healthcare will be moving in that same direction.
Judd, are you seeing a move out of California in the assets, or do you see continued growth here?
I definitely see continued growth here. I think what we are just on the very edge of tapping what this resource has to offer. And I think what we're going to continue to do is make the data more and more useful for a wide variety of applications, both as we learn, but also as the market learns how to use the data, and how different ways to apply it and how to create new opportunities out of it. So I think we're just barely tapping that potential right now.
Well, Judsen Schneider, Curt Allen, Nashville Biosciences. Thanks, gents. Always great to see you guys.
Thanks for having us.
We look forward to working with you in the future.
Excellent.
Cheers.
Thank you. Cheers.
Appreciate it.
The executive producer of the Vital Health podcast is Duane Schulthess. Our editor is Mark Brodeen. Our project manager is Gwen O'Laughlin. The Vital Health podcast is a production of Vital Transformation, LLC, copyright 2024.